Good evening, everyone. Thank you very much, Mukshan Patil sir, for introducing the technology in orthopedics. So my topic is how robotics is being used in knee replacement. So when you go to the technology in orthopedics, especially in arthroplasty, many revolutionary changes have been happened over last 30 years. So when we consider technology specifically in joint replacement surgery, we can divide into three categories. One is fast, which has been already done. Present is robotics, and future is augmented reality and artificial intelligence. The old technology like patient-specific instrumentation and navigation went out of fashion because of many important features it was not giving. The main important was it was not giving tactile feedback. So for any act in the operation theater, somebody has to give us feedback that you are right, you are wrong. So that was lacking in the previous system, previous arthroplasty technology. That is being implemented in the present technology, that is robotics. So what is robo? Robo is nothing but it's a which means forced labor in English language. Uh, in alternate terms, it is called as a machine where multiple tasks are taken automatically with minimal external impulse, or and it's pre-programmed. So this is the definition of the robotics. So when we go into the robotic evolution, there was a static plan in the early 50s. Then in 90s there was a navigated execution. In the early first decade of 2000, it was navigated freehand technology, and second decade the robotic era started. Why robot is important in the present knee replacement surgery? In the knee replacement surgery, around 10 to 15% of the people remain unhappy, even though you have done best of your efforts. That is because we don't have control on intraoperative few parameters which are very, very important, like alignment, which is patient specific. Second is soft tissue balancing. Third is component sizing. So most of the time, these factors cannot be accurately done in manually. So these are the around 8 to 15% of the people may remain unhappy. That's the thing. The technology may bring difference. The future will tell of collaborating the elaborative data. So these are the three parameters: lower leg alignment, component positioning, soft tissue balancing. So when you have tighter control on these three important things, then our patient satisfaction will be definitely better. So these factors were not so well controlled in the previous technology, like patient specific instrumentation and computer navigation. That's why they went obsolete. The present is robotic assisted surgery, so where we can get the functional alignment for each and every patient. There is an alignment which is needed for each patient. The MACDESI has classified our knee into multiple varieties. So all doesn't need the mechanical conventional alignment what we do. Some patient need functional alignment, some patient need mechanical alignment, some patient need limited kinetic alignment. This is little higher terms in the orthopedic terminologies, but however, patient specific alignment is what is required presently. So there are many robots available in the industry. The few when we classify without the name of the company can be classified as active robots, passive robots, and semi-active robots. And active robots is perform the task independent of the surgeon, whereas passive robots need some. I mean, surgeon control is minimal. Whereas semi-active, both robotic and surgeon both have an important role. Semi-active robotics have a haptic boundary where your cut is limited. Like you cannot cut beyond the safety margin, and it is completely controlled both by robot and surgeon. That is technology and surgeon, and accuracy of the bone cuts are in millimeter. And there is a huge soft tissue protection. You can see here that there are two lines. One is the green boundary where you have to cut, and there is one rectangular type of the boundary where the even if you force the saw blade, it will not go uncut. So that's why the semi-active robo with double check mechanism has become more important in nowadays. So it always gives precision, very minimal trauma to the soft tissue. It is higher safety, more flexible, and it's more surgeon controlled and yet not surgeon dependent, and it's been clinically proven. So many literature also supports the robotic in terms of restoration of the joint line, and also to provide a greater accuracy of implant position, how to keep the implants. And also we have done a small audit where soft tissue protection is better in compared to the conventional surgeries, because we don't release in conventional surgery. We have to completely deliver the tibia and cut. Here, very minimal cuts and very less bone preserving surgery, very less soft tissue damage. So eventually, it results in early rehabilitation, less pain, and early go home. And many cohort studies have demonstrated that functional recovery and reduced hospital stay. So everybody thinks newer technology means more money, more investment. Yeah, that's true. But when they have done a hospital readmission surveillance in US and also the number of the days, extra days what they stay even the manual surgery, the augmented cost in 5 days, 5 years is more when compared to the robotic surgery. That means whatever robotic they're initial investing, that is lesser than the readmission rates and the complications due to loosening and so on. So overall, it is scientifically accurate precision. Second thing, economically also beneficial in the long term. As I told, soft tissue balancing is very much improved because of the feedback mechanism what the robot gives. So we'll go with one of our example is a 75-year-old gentleman with bilateral osteoarthritis, limited his day-to-day activities because he's a very active man, but limited his activities. So this is his pre-operative range of movements. This is how he is his gait cycle walking. So then when we decide he will go for surgery, so we do CT scan. So pre-operatively, that is called as functional CT scan. Functional CT scan, the radiation exposure is much less than the conventional X-rays what we take. For a conventional knee replacement surgery, we take a scanogram, we take both knee standing AP and lateral, we take a pelvis X-ray, and sometimes we take LS spine X-ray also. So combined X-ray, combined radiation exposure is equivalent or less than the functional CT scan what we do. So the radiation exposure also is very minimal. So after once we send the CT scan to the Mako program system programmer, we will assess and send to the where they orient the complete software and involve which implant to be used, what size implant has to be assessed, and how to keep the component, how many degrees of varus alignment has to be given. So all these technical terms, they will give a nice feedback. There is a system for that. There is a software there that they will assess and send it back. So when it's a patient CT scan is mapped, the vital templates are being made, and everything is assessed and complete data of pre-operative planning, including the size of the implants are given. So with all this information, we'll go inside. When we go inside the theater before the incision, we know what size of implant we are going to put, and we know what are the osteophytes, where is the limiting factors for the flexion like bending and all. So these are the parameters we look at. So we first go and check the hip center, then we check the butterfly of the medial epicondyle and sulcus lateral epicondyle, and these are the other parameters for the resection. So where we are resecting, how much bone we are resecting, it will show. So this is what I was telling you. So this is how it looked before the surgery. Implant already. This is the most important. You can see here. We can see how the patella is gliding. Most of the patients who are unhappy post TKR are due to anterior knee pain. The pain they will have in the front of the knee even after the best surgery. So in robotic, we can assess whether we are overstuffing the anterior compartment. So we can then and there itself change. For example, medial lateral, the Asians have medial lateral and interposterior diameter variation. So we can change the component accordingly and fit the proper implant so they will not stuff the anterior compartment, and we can reduce the anterior knee pain. So these are the multiple advantages, and this is how the setup is made. And once we setup is made, this is intraoperatively we make the alignment so that the CT anatomy is in the computer. We have to align the live anatomy to the camera. So now we are aligning the computer to the our real system. So then when we do that, then we will also do the how to in all the angles that the robotic arm is has to be adjusted to the camera in all the angles from 0 to 120 degrees. So that is mapped. When everything says yes, then we do the arthrotomy. Then we do femoral arrays, like we'll put some stems and arrays in the femoral side, and we'll put 2 more pins in the tibial side, and those are the visa discs what you are seeing. Then when we align them, this is how the hip rotation is done. So this is after the all the anatomy is matched and the arrays are put. These will be facing the camera. then we have to capture the hip center. That is already hip center is there through CT scan. So to capture once again, see you can see in the that picture. So here it is showing as that is called as guiding module. So once the guiding module everything is confirmed, we tighten the so that the pin should not move. So once that is done, then once again we take our probe and remark the live anatomy like medial malleus, lateral malleus, epicondyles, hip center, everything, so that the both anatomies are matched. Once the assembly is adjusted, this will how it look. Okay. So then these are the checkpoints also. There are checkpoints for the femur, there is a checkpoint for the tibia, which tell us how many millimeter we are away from the checkpoint. So if there is any variation in our cuts, it will tell us, see, you are going away, or there is an error. So it will always give you feedback, so like somebody who is constantly monitors in the house, like our wife. Yeah, you are right or wrong. So constantly it will monitor us. So that's why the robotic. There is nobody to monitor in the OT. Only we ourselves used to monitor. There is some inert person who is non-political and accurate and scientific, who is monitoring us. That's why the technology we should believe. So after this also, it will not allow us to cut. We have to cross confirm. So whether we are all the matches are correctly matching. So there will be some more bubbles we have to rupture so that the anatomy is matched. Once we done that, we have to distract the soft tissues to address how much is the soft tissue laxity we have to create. So if you can see here, now this is most important. See it after giving a stress, this should be around 18 to 19 mm. Okay, so these all values should be, then only the knee is balanced. So now you can see on the lateral side, L means lateral, M means medial. So lateral side we have 21, 21, medial side we have 50. That means medial side is contracted, lateral side is open. So when you do accurately changing some parameters and all these parameters when you cross check and change it. So this is how I put this video to demonstrate how that haptic boundary controls us by cutting more and less. The green color what you are seeing on the screen is the bone to be removed, and this is the assisted. So it is completely surgeon control but not controlled. So like it will never allow you to move out of the haptic boundary. So now you can see the same values what were there initially 21 to 15. So they all become 18. So that is the beauty. So this cannot be done in manual technique. So this is a patient post-operative X-ray where functional alignment technology has been used. So this is the X-ray, and as I said, the TJ is even cost-effective. This is done with hip replacement, one of the another study. So then when you use the technology judiciously, so definitely patient will be happy, and definitely they will rehabilitate early. They will come walking. All these patients have come walking for suture removal without any assistance, without any knee brace, without any walker support. So having said that, one more patient to demonstrate how good it is. So it is a first post-operative day. He is walking unassisted. He is 81-year-old. He is walking unassisted without any support. So that much accuracy, this precision and soft tissue balancing in accurate, like even in millimeters, will give that much confidence to the patient so that they can walk independently, walk early, and rehabilitation is faster. So I conclude my talk by saying that to fail to adopt a new techniques would have mean we are denying the patient the meaningful technical services and advances. Thank you, Wanda.